be posted. So now, once again, let me welcome everyone to our webinar on Innovative Research Partnerships, Building a Risk Assessment Tool for the New Hampshire Bureau of Elderly and Adult Services. Today's event is co-sponsored by the Ash Center's Government Innovators Network and the National Institute of Justice. Our moderator today is Andy Mao, Senior Counsel for Healthcare Fraud and Elder Justice at the U.S. Department of Justice. Andy will be starting us off today. Andy?
Good afternoon, everyone, and welcome to today's webinar. Notwithstanding our rapidly aging population, there are obviously many questions that remain and still much that we have to learn about elder mistreatment. We have really basic questions that we need the answers to, including why does elder mistreatment occur? What are the risk factors? Are there effective preventative measures? And are there any successful interventions or treatments of elder abuse and neglect? Notwithstanding the critical need for these answers, researchers are sometimes reticent to conduct research on the elderly, given some of the challenges that may arise. Some of these may involve identifying potential victims, which we know is an issue, especially given the fact that elder mistreatment is so significantly underreported. Another issue is protecting the safety and confidentiality of potential elder abuse victims. There are issues involving capacity and consent as well. Given all these challenges, it's not surprising that research has lagged somewhat in the elder abuse and neglect field. However, the good news is that there are those that have done work and can help those who want to enter this area and work with the elderly to navigate those waters. Today's webinar is going to focus on one such successful collaboration, as Jessica mentioned, involving the development of an actuarial risk assessment tool to help identify potential and categorize victims of elder mistreatment. This project was chosen for a number of reasons. One, obviously there's a real hunger out there for any type of tool to help people do risk assessment analyses. Now, while this tool isn't completely complete and the research is not yet complete, it is an innovative way to think of things and something that we should talk about. Another reason why we picked this particular project is because it shows a successful collaboration between a researcher and Adult Protective Services, which Kathleen will talk about in more detail. Lastly, I think it highlights the amount of thought, preparation, and consideration that the National Adult Protective Services Administration has given to the issue of elder mistreatment research, and what a viable and amazing partner they can be in helping those interested in doing elder mistreatment type research. With that, I want to introduce our really phenomenal panel. Our first speaker is going to be Kathleen Quinn, who is the Executive Director for the National Adult Protective Services Association, the only national organization representing adult protective services, programs, professionals, and clients. Kathleen has extensive experience working on elder abuse issues, having served as a policy advisor on senior issues to the Illinois Attorney General, as well as the Chief of the Bureau of Elder Rights for the Illinois Department of Aging. Our second panelist and speaker is going to be Kristen Johnson, who's a senior researcher with the National Council on Crime and Delinquency. She spent much of the last 5 years conducting research on the design and evaluation of decision support tools in adult protective services in New Hampshire and California. Our last panelist and speaker is Rachel Lakin, who's an administrator for the New Hampshire Adult Protective Services. Rachel's worked in APS for over 13 years as both as an APS social worker, supervisor, and now administrator. Her past work has included dealing with child welfare and developmental services, and she has worked on the New Hampshire SDM project since its inception. So with that, I want to turn it over to Kathleen Quinn, who will introduce us to NADSA and the work that is done regarding research and some of the broader sort of policy objectives there. So Kathleen.
Thank you very much, Andy. Thanks to everybody at NIJ and Harvard, everyone involved in today's webinar. And welcome to all of you across the country who have joined us. I'm very pleased and very honored to be part of the discussion today. This is a very important topic, of course, which is really very much needed research into elder abuse and APS. Andy already talked a little bit about NAPSA. I would also mention that we have just recently been funded by the U.S. Administration on Aging to create the first National APS Resource Center, which we are really excited about. The purpose of the center is to help build capacity in APS across the country. And we also host the only national annual conference on elder and vulnerable adult abuse in APS, and we invite everyone to join us in Scottsdale, Arizona in mid-October this year. We're going to be partnering with the Arizona Attorney General and Arizona APS, and we're going to end with NICP, which I'm going to talk about in a minute, and I think we're going to have another terrific conference. Now, I'm sure virtually everybody on the call knows what APS is and what APS does, but just in case there's anybody new to the field, very briefly, APS operates under state law in every state to receive and to investigate abuse, neglect, and receive reports of and investigate abuse, neglect, and exploitation of elder and vulnerable adults. Vulnerable is defined in state law, and then APS intervenes to protect the victims to the extent possible. In most states, APS responds to the abuse of all vulnerable adults 18 years and older, so it's the entire adult age range. One of the important things to understand about APS is that it can differ fairly significantly from state to state, and in states where the program is administered at the local level, it can even differ from county to county in terms of eligibility requirements, definitions, services, and resources. There's never been a national support system for APS, so every state has evolved its program separately, so there can be quite a lot of variation. The important thing is to understand how APS works in your locale and what its parameters are, what its role is, and what its limitations are. So I'm here today really to talk principally about this wonderful committee, the NAPSA-NICP Joint Research Committee. Our sister organization, the National Committee for the Prevention of Elder Abuse, or NICP, joined with NAPSA a couple years ago to form a very active and very productive joint research committee. The committee has representation from APS, of course, and from elder abuse experts, but also from academia, researchers, and federal agencies such as the Department of Justice, Administration on Aging, and CDC. It is co-chaired by Carol Dayton of NAPSA and Paula Mixon of NICP. In addition to the products I'm going to discuss today, the committee also provides, through our member, the National Council on Crime and Delinquency, quarterly webcasts on research which has the potential to influence practice. Look for notices and invitations to those webcasts on the National Elder Abuse Listserv, and we're going to now shortly have an APS-specific listserv, so you will see notices and invitations to join the webinars. They're free. They are being produced as part of the National Resource Center now, and they've really been excellent. They've gotten really good evaluations on those. So what I'm going to talk about principally is 3 documents that the committee has created. These are all available on our website, which you can see there, apsnetwork.org. The first document is really a cover memo, an introduction to the other 2 documents. It describes the committee and gives an overview of the other 2 documents. So the 2 primary documents are guiding principles for research in APS and guidelines for evaluating and applying research in APS. And I'm going to go through these a little bit more specifically. And I want to thank Carol Dayton because I'm going to read a couple things that she had written for an article that appeared in VED about the committee's work. The first document I just mentioned, Guiding Principles for Research in APS, provides a set of principles and practical steps to encourage research that will increase knowledge and support best practices. The underlying premise is that knowledge is power, and increased power can strengthen advocacy not only for individual clients, but also can support the development of expanded resources that benefit all. The document provides specific steps to address risks, data collection, and staff input with guidance for 3 types of research projects. And I want to say parenthetically that these documents are brief, to the point, very easy to read. They were definitely designed with busy practitioners in mind. So they're very, very they have very, very accessible information. So I'm going to walk through the guiding principles just so you have an idea of what's in there. I've already said knowledge is power. The committee believes that APS policy and practice must be based on sound data. And it goes without saying that APS's top priority must always be the needs of the clients and the safety of the clients. That's always going to be paramount. That advancing APS knowledge and improving client outcomes, in order to do that, APS staff have to have some time available to participate in research. That there is a cost involved in terms of APS being involved in research, and that is principally the time that it takes for staff to provide the data, to join in the project. And you'll hear much more specific information about the New Hampshire example in a minute. And finally, lastly, APS records contain a wealth of data which we think is not always utilized to the extent that it could be, including safety and risk factors, initial onset characteristics, reporting patterns, investigation outcomes, and the protection of rights of vulnerable and elder adults. And also part of the guiding principles is that both NAPSA and NCPI encourage all of our members to cooperate with research to the extent possible. So if approached by a researcher about involving your program, your project in a research project, we hope that people will try to think how it's possible to make that happen. And also to initiate research goals and protocols yourselves, and you'll hear about New Hampshire doing that today. And then, of course, to make available and to discuss and to use these guidelines with your staff, with the decision makers in your organization. And then there's a few recommendations for researchers, which, again, this sort of goes without saying, but that researchers must maintain the confidentiality of all data. They must abide by applicable regulations regarding the use of that data, and they really should set the stage very early on at the beginning of the project to involve APS staff as broadly as possible, and to really promote candor and to allay concerns about possible negative outcomes of research. We know everybody's under severe budget stress and has been for several years now. People are really worried about losing funding, and that may happen in any event, but the possibility of research findings coming out saying maybe this program or this approach or this intervention is not successful, people worry about the backlash that may come out of that. And we think by getting that out on the table early on and talking that through will help build support for the research within the organization. And part of that also is ensuring that this APS staff understands the purpose of the research, how the data will be used, how the outcomes will be shared and with whom. And then don't forget to talk about how the media will be involved. Will the results be distributed to the media? Will there be publicity? What's that going to look like? And the sooner that all happens, the better the project will go. Then the second document is guidelines for evaluating and using research in APS. And this was written for practitioners who may see studies, whether it's in Journal of Elder Abuse and Neglect or the Victimization of the Elderly and Disabled or any other, the gerontologist, any other kind of publication, and wonder whether that research is applicable to their work. So this document was developed to increase the understanding and application of research findings by direct service staff and administrators. It includes a glossary of terms and a case study of a successful research project that dramatically changed and improved APS practice. The document's intended to be a primer on research to encourage practitioners who might be hesitant to enter the unfamiliar world of research due to uncertainty about its relevance and value to their daily work with clients in crisis. But until research is valued by the practitioner, its impact on improving practice will be minimal. So this document's a little bit longer, again, very, very accessible. And as I've already said, it covers the challenges and benefits of applying research to APS. The case example used is the University of California at Irvine bruising study, which I know many of you are familiar with. The research was carried out by Dr. Laura Mosqueda. And it's a really good example of how the APS program came to use the findings of that research study very productively to benefit clients. The document also includes just a paragraph describing different types of research. So basic research, which is knowledge, the building of knowledge for future applications. And applied research, of course, is research that looks at an immediate practical application. And needless to say, you need both kinds of research. And then you have quantitative versus qualitative. The bias, I think, is very strongly toward quantitative research. Anything you can document with numbers is, up there. Qualitative can also be very excellent research, and it's based more on interviews, case studies, and so on. And then it lists a series of really useful questions, I think, for people to use as a checklist when reading a study. Is the study relevant to your work? Obviously, that's a good question to start with. How long was the program being described in operation? Did the article list what the study's limitations were? Is there evidence resulting from the practice? Were there outcomes that can be pointed to and documented? Did they define the outcomes at the beginning, and did the results address those outcomes, whether they worked or they didn't work? Was the sample size sufficient? Obviously, if you have a real tiny study, it may not be generalizable to larger population groups, or if it's in a particular minority group, for example, it may not be completely generalizable to the population at large. More questions. Were the sample and the outcomes relevant to the population that you serve? Already said, can you generalize the findings? Did the study list implications for future research? And was the study published in a peer-reviewed journal? So that's a really important credibility and quality measure. If it was in a peer-reviewed journal, it has a higher standing in the research world. Already mentioned there's a glossary of terms provided in the paper. And then the paper also lists the challenges that, of course, accompany research into APS. Client confidentiality is always a major issue and concern. And, of course, same goes for lack of time, staff time and resources, always a huge concern in programs which are already overwhelmed with the number of clients and crises that they deal with every day. They may not see the benefit to the program in putting in this time and the resources, and they're going to be worried about negative outcomes. So again, those things can be addressed and talked through at the beginning, not to say there's no possibility for negative outcomes, but talking through how those will be handled and so on will help garner support for the program.
How about with consent issues, Kathleen?
I'm sorry?
How about with consent issues? How do APS workers assist researchers in making sure that potential victims of elder mistreatment are able to give their consent in order to participate? Is that something that APS workers have helped researchers with?
Well, that is a big, big concern, and it depends on how the data is being used. If you're using aggregate data where you don't have any client identifying information even possible, that's not as big a concern. Right. If you are using data that can be linked back to specific clients or even maybe types of clients. That is a concern, and of course a lot of APS clients are not able to give consent. So that would either limit the study or, some other provisions would have to be made to address that. And I think that would depend on, each program and what their laws are and what their parameters are and so on.
Thank you.
Mm-hmm. And so finally, we have to look not only at the challenges, of course, but at the positive outcomes of research, which is that we will improve APS practice so that clients are provided more safety, more effective services, and that APS itself becomes more efficient. I want to add one thing before concluding, and that is that there is another document that the committee is just beginning to produce, and that's a one-page summary of research of interest to APS practitioners and others in the elder vulnerable adults field. It's called R2, number 2, R2P, or Research to Practice. The first one was just distributed. It's on the Elder Abuse Listserv, et cetera, and it's on our website. And we did 2 earlier ones in a different format that we will put into the new format. And the committee will be periodically developing these as we find research that is of interest and has the potential to impact practice. So in conclusion, NAPS and NICP, through the research committee, strongly support and encourage greatly needed research into adult abuse and APS, and we are happy to cooperate in any way we can to support such efforts. And now I'll turn this back over to Andy.
Kathleen, one other question. To the extent that somebody wants to pose a question or seek guidance from the committee directly, what's the best way for them to reach out to the committee?
I think you can just email info@napsrc.org. That's the National APS Resource Center, napsrc.org. And I or Andy Capehart, the Assistant Director, will get those messages, and we will take them to the committee.
Great. So maybe we can ask, at the end of it, we can ask Jessica to help post that web address on the Innovators website so people can get that as well.
Yes, and my email address is up on the slide right now if anybody wants it.
Great. Thank you, Kathleen. If we could turn to Kristen now. Kristen, you still there?
Hi, yes, I am.
Great. It's all yours.
Alrighty. I am part of the crew at NCCD that worked with New Hampshire Bureau of Elderly and Adult Services. And I want to start out by acknowledging our many, many partners. There are too many individuals to list, but in general, we worked with New Hampshire Bureau of Elderly and Adult Services since 2007. This research was initiated by them. They contacted us when they had a grant, and they wanted assistance developing valid and reliable assessments for APS workers to use under these difficult working conditions. APS is chronically underfunded, workloads are increasing, so they wanted some help developing valid and reliable assessments, and NCCD has experience developing similar assessments for child welfare and juvenile justice and adult corrections. So we started working together early on in 2007, way before the NIJ grant, and started with a literature review and understanding APS and the issues that Kathleen just went over. And we basically designed a project and then went forward as if we were going to get funding. And we're very optimistic, and then that optimism seems to have paid off. In late 2008, we received a grant from the National Institute of Justice that focused on developing a risk assessment tool. Phase 1 was preliminary tool development. We worked with BEAS workers to design a data collection instrument that they completed at the end of investigations. And so phase 1 was looking at that data relative to outcomes and doing reliability testing of the tool. Year 2, which is also phase 2, was a process evaluation and then data monitoring. So the process evaluation used both quantitative and qualitative sources of information to examine how useful this was to practice, in addition to the validity and reliability. And then phase 3, we're in the middle of, and that's a validation study. So with a separate population, does the risk assessment developed in phase 1 prove to be valid at classifying adults by the likelihood of subsequent maltreatment? So I'm not going to go into great detail about the project. The first report from phase 1 is listed on the resources page of the Innovations website, and you can contact me if you have more information. But overall, the purpose of the research was to develop an actuarial risk assessment so that at the end of an investigation, APS workers could effectively classify adults by the likelihood of future harm or self-neglect. And the reason for this would be so that the intensity with which one pursued engagement could be differentiated by the risk level assigned. And again, the overall objective is to focus engagement on the adults at the greatest risk of future harm. So I briefly just want to show you the results of phase 1, the risk assessment. We ended up developing 2 indices that are part of the same assessment, one for self-neglect and one for abuse or neglect by someone else. Because as the literature shows in the community and in the APS population, the risk factors for self-neglect differ from the risk factors for abuse or neglect by someone else. In general, what you see is very typical. So the phase 1 risk assessment performed well when classifying. So of the adults that were classified as low risk, only 5% were reinvestigated, and only 2% had a substantiation during the 6-month follow-up period. And then what you see is a significant increase in the rate of reinvestigation, substantiation, based on the risk classification. And the overall level that you see, the overall risk level, is the higher of the 2. So there's a risk level for subsequent maltreatment by another person, and then there's a risk level for self-neglect, and the overall, again, is the higher of the 2. I wanted to show you quickly that the proportion that are classified as high risk is relatively small, which means, again, that the tool is useful and has some validity. We would expect that moderate, which is based on, it's an average, right? So those adults classified as moderate had average rates of reinvestigation. Those classified as higher risk had higher than average rates. And those classified as low, lower than average. But again, the proportion that were classified as high risk is 14%. So it means it's an effective population for a more serious prevention effort. I wanted to briefly mention, because this is about working with APS agencies in general, for us, we collected information from APS workers, not actual clients, so we didn't have to worry about client confidentiality. We did, though, involve APS workers, supervisors, and managers in every step of the process as often as we could. And I'd have to say that was just incredibly useful because they provided a check and balance at every point and constantly made sure that what we were doing was useful to them. And then I'd have to say the MIJ grant was extremely helpful because it connected us with a bunch of researchers and gave us numerous sources of information. And we actually ended up in phase 1 setting up an informal advisory group who reviewed our preliminary findings. So that was very helpful. And then, just so that people know, we developed a web-based data collection instrument. And that allowed us to change the tool and refine it prior to implementing it statewide in their MIS system. So it provided a much more affordable means of testing a tool in practice settings, which I think is just useful because, again, the MIS systems can be very expensive to change.
Did you have to provide training to the APS workers to help them work on the data collection tool?
We did. It's fairly straightforward to use, and we made it very friendly. For example, when you answer a risk factor, if you right-click on the item, it popped up the definition, because I think definitions are key to reliability. So we made it very user-friendly. We did give them a brief training. And then we ended up, or actually I should say Rachel ended up doing, I think, much more training and support on site about how this information applies to practice. Because it's one training to complete the assessment and understand its origins, but applying it to practice and how it fits in with engagement skills and how you collect the information is a whole other issue. And I think BES has found that they needed to do additional trainings.
Right. And is the risk assessment data collection, the instrument itself, included in the report that is on the resources, on the innovations resource site?
Yeah, the assessment in paper form is in that report. Yes.
Great. Thank you.
Sure. Lessons learned for us, what I think our big issue is that APS outcomes are different than child welfare, right, for obvious reasons. And it would be helpful to know more exactly what happened to clients who were involved with APS. For example, which resulted in legal prosecution and which did not. Which clients ended up in long-term care or died immediately following the investigation. There may be adults that we consider eligible for subsequent maltreatment when in fact they're not because of the setting that they're in. So I think there's a great need to better understand what interventions APS workers put in place and then what impact that has on outcomes, what happens to them. And then I think also, given the difference in APS practices nationwide, in order to argue for more resources, I think we need to show the effectiveness of this short-term monitoring, either using the risk assessment or not, right? But I think it would be very helpful for the field to show that doing short-term monitoring can prevent recurrent harm. And then lastly, both of these would help support and create an evidence base for the advocacy work that Kathleen talked about. I think there's a strong need for us to document the role of APS workers as first responders and show that the service that they provide is so critical and that they end up monitoring clients that may not come to have the same visibility with other public service agencies.
Great. And then one quick question. In terms of the validation part of the project, when is that expected to be completed? Phase 3.
September. I'd say September of this year. We are just now looking at 6-month outcomes. And it's been pretty interesting. In general, the tool works well. There's certainly a number of issues, and I think for me the validation I'd really like to know which adults are eligible for reinvestigation and which aren't. But 6-month results show that the tool works, but we want to look at 1-year outcomes as well. So we'll have a number of reports and articles coming out, but we should have the final validation report done this summer, September at the latest.
That's great. Have there been any sort of surprises based upon the preliminary data gathered?
Surprises, I would say the maltreatment index is of particular interest to me. And I would say NIJ too. I mean, it's been interesting to find that any critiques of the grant have been because there seems to be a large focus on self-neglect. But as we know, the self-neglect represents the largest proportion of harm. So what I'm particularly interested in is of those who are reported for self-neglect, then how many are subsequently referred for neglect or abuse by someone else, right? So perhaps because of the intervention put in place. And so we do see some self-neglect individuals coming back, or I should say referred again for abuse or maltreatment by someone else. But I'm watching 12-month outcomes. I'd really like to see over the next year who is referred for abuse or neglect by someone else. And of those referred at the initial sample event for maltreatment by someone else, who is then referred for self-neglect later.
And Kristen, how many unique clients were there as part of this study sample?
In phase 1, I'm estimating, but I'd say roughly 680. And then for this phase 2, we did get a delay in the project, and part of that was because we wanted a larger sample. So for phase 3, the validation effort, we're looking at approximately 1,060 individuals in the sample.
Wow.
Base rates are low, and so for those of you familiar with actuarial risk assessment, the average rate of reinvestigation and substantiation plays very heavily into one's ability to distinguish people based on risk factors related to recurrence. So, I mean, again, I think the comparison of risk factors identified relative to 6-month outcomes and risk factors relative to 12-month outcomes will be interesting.
Kristen, we've gotten a couple of questions already. One of the questions was whether or not you tracked who reported the cases, whether or not it was police agencies or some other type of community agency.
We have, yes. We did collect reporter information. Yeah, I'd have to say Kathleen's right. I mean, there's a wealth of data. I actually had a call before this about what we want to look at in the next few months, and the list is long. So we did collect reporter information. We have a living arrangement. I mean, we have all of the data that we collected in the risk assessment and some supplemental factors that workers wanted us to collect to see if they became a risk factor in the tool as part of the phase 3 study. And then we also have all of the data that is in their administrative system. And then we have safety factors. So there's a wealth of information to look at.
And could you talk briefly about what the categories of reporters were? Just some of them?
I can. I don't have the figures in front of me. That might be something, I'm not, in terms of frequency?
No, just the general categories of potential of reporters.
Sure. You get a lot of reports from hospitals and medical care facilities, right? You know, similar to child welfare, I think we have some education to do about reporters and what signs to look for. And so you get a lot of referrals from hospitals, physicians, or nurses. There are police reports. I'm trying to think, financial exploitation in a number of states now. Banks are mandated reporters. So I haven't looked, but I expect states like California, after having passed that law, to have an increase in the number of banks reporting financial exploitation. And I think that's another thing that we're looking forward to looking at, right? What is recurrence rate by the individual type of maltreatment?
That makes total sense. A couple of people have written in questions about whether or not the risk assessment tool will be made available. As we talked about before, it's actually included in the as an appendix to the full report that's on the Innovations resource site. So that is available.
It is, yeah. We'd very much like to, I mean, one of NIJ's concerns, I hope I'm reflecting their interests correctly, but one of their concerns is that New Hampshire is a small state and perhaps not representative of other populations in the U.S. And so if what we've asked is that if agencies want to explore using the tool, we could certainly help do some of that research, right? Because it would be, I think, part of what is needed in the future is to know this risk assessment that was developed for a New Hampshire population. How does this perform when it's imported to another state with different populations, different policies? You know, these are things, so I would encourage people, if they want to explore using the risk assessment, to contact us and see what research we could do that would test how it performs in their jurisdiction.
One last question before turning it over to Rachel, which was, did the APS staff inform their clients that they would be part of the study, even though they weren't directly interviewed? The fact that their information would be part of the sort of aggregate data considered, was there any sort of informing of the clients?
I don't believe there was. Because we were using aggregate information, the study was designed that we would get most of our information from APS workers, and we're very careful to look and think in aggregate form. And we did do some case reviews, but we did those after the fact for closed investigations. I don't know that APS workers told clients that we were going to use their data to see if we could better identify risk factors for maltreatment. That's a good question.
Okay. Well, on that note, maybe we could turn it over to your colleague on this. Rachel?
Hello. No, we did not inform clients that we were collecting data and submitting it. And I'm waiting for my slides.
Here they are.
Rachel?
Yes, I'm here.
Okay.
And I'm waiting. I don't see my slides.
I see your slide, Rachel. So I can tell you that the slide 1 is up now. If you can't see it, I'm happy to sort of walk you through. You can let me know when to change it.
Sorry, folks. That's not looking familiar to me. Well, my name is Rachel Lakin, and I am the Adult Protective Services Administrator for the state of New Hampshire. And we investigate reports of abuse, neglect, and self-neglect of incapacitated adults for anybody who's over the age of 18. And we have around 40 adult protective social workers on any given day, and we have 12 district offices throughout the state of New Hampshire. And for state fiscal year 2011, we received 2,540 reports that we looked into. And basically today I've been asked to talk about 3 things. What should agencies consider before they get started in the research? The second thing I've been asked to speak about is, have practices in my agency changed as a result of the research? And 3, what has made the relationship with the researchers work? Andy, if you could go to the second slide.
I can.
Okay, because I see no slides on my computer. But I will go ahead with what I have here.
I'll be your wingman. The second slide is up.
Okay, thank you. So I thought in order to talk about what agencies should think about, I would describe to you what New Hampshire considered in getting started with what we call structured decision making. And the risk assessment tool is one of 4 tools that we use, that we worked with the National Center for Crime and Delinquency. So I'm going to talk about the whole process, but the risk assessment is a very big piece of that process, naturally. What we saw is that we had, as I said, 12 district offices, and what we knew is that depending on what district office a call got, or a report got called into, it might be handled very differently. It might even be handled very differently from each worker in the office. And so what we wanted to do was bring consistency to how we handled adult protective reports and investigations. We wanted to improve our practice, and we wanted to strive for best practice. And we also wanted to look at our work and then also, based on that, assess what our outcomes look like. Third slide, please. So then, of course, the next thing is how, to consider is how do we pay for all this? We were fortunate. We received an initial grant through the Centers for Medicare and Medicaid Services, and we put out an RFP, request for proposal, to develop structured decision-making assessments. And we were familiar with structured decision-making from our child welfare agency. So we kind of knew we wanted something similar to what they used. What we then did was, with NCCD, is we developed a work group. And I want to talk about the work group a little bit. I think what we considered and what I think folks engaging in this process should consider is who are the people that are really going to bring this together for you, because it's quite a commitment over time. And what we learned when we brought everybody together is just how different everybody did do things. And so we had to discuss that and get through that and try to decide on what is it that we want New Hampshire to look like. And one of the people that I do want to recognize as part of the work group is our project coordinator, Sally Varney, who I think states it was critical for us, and I think it would be critical for all people considering this, is to really have a designated person as a project coordinator, because it is a lot of work to facilitate the meetings, to do follow-up. I kind of see Sally as the glue that held us all together through this process. Very instrumental in being a liaison between the work group and the contractors, NCCD. So that's a very important role. And then I think Kathleen was talking about having involvement from every level of your service system, and I think that's important. We brought together a work group that consisted of our field staff, our supervisors, our administrators, and that was the ongoing work group that we had. And I think it's what's helped us is we still have our administration as very supportive of our structured decision-making model, and that's critical, I think, as we implement and as we go through the process. Fourth slide, please. So have practices in our agency changed as a result with working with the researchers? I'd like to say, for those who may not know this, change does not come without its challenges. And New Hampshire certainly faced a lot of challenges. One was that our IT system, it was hard to get our instruments into the IT system. And as I think Kristen was talking about, that sometimes is a good thing because it gives you an opportunity to really work with it and revise it and edit it so that it is more of what you would like it to be. Fifth slide, please. We also had, even though we involved people, we took people from different offices and brought them in and had them sit and work on the tools with us. We still had a number of staff that it took them a long time to get on board with doing things differently. And I do know one of the things that was a challenge was they did have some resistance to collecting information on clients. They were a little unsure about the web-based system and putting stuff out there on the internet. And so we did have to work through some of that with folks and reassure them that it was secure. Many staff, I told you that we were looking at a model similar to what the child welfare system in our state used, and many people did not feel that we should be comparing ourselves to the Child Protective Program. Sixth slide, please. After we implemented our structured decision making, we conducted a process evaluation, and as you can see, we weren't surprised by the results. That we had many people who didn't think what we were doing was useful, and it seems that the more experience a person had, the less useful they felt the instruments were. Seventh slide, please. Next slide. So to this end, we took some action steps because we figured that what we really looked at was we don't think people are understanding what, that not just to do the tools, but to also take the data from the tools, the information from the tools, and really apply it or integrate it into their practice. So we started to meet with the district office supervisors, and we found some interesting, pieces of information from those meetings. We sat down with them. We were able to show them the data from their offices, and we were able to say, your risk assessment says that you had X number of people that were high risk, yet you did not open any of those cases. And so what we found was that, number one, some clients didn't want us to, become involved with them. And what we also found was that some district offices were actually doing the work as part of the investigation when we clearly wanted that to be two separate processes. We also have monthly supervisors meeting where we have structured decision making, and we're as part of our agenda, and we're also able to provide the supervisors with information about their office and also about how their office's statistics compare to statewide statistics. And that has been very helpful. Next slide, please. Okay, so we have seen some changes in practice. What first of all we've done is prior to the risk assessment, we would open cases based on whether or not the investigation was founded or unfounded, and whether or not that individual was in need of protective services. What we learned from our work with the contractors was that people were at risk regardless of the outcome, whether the investigation was founded or unfounded. So we're asking staff now to open cases based on a risk level. So in New Hampshire, we have a low risk, moderate risk, or high risk. And basically what we're saying to staff is we want you to concentrate on those individuals that score as moderate or high risk and open those cases. And we've also established, I think Kristen called it dosage of contacts, but we have established contact standards for each one of those. And so there's some expectation if somebody's a moderate risk, has scored as a moderate risk client, we're going to see them a couple times a month. In the past, we would have, if we've opened a case, we would have only asked the social worker to see them one time a month. We also, as part of the structured decision-making risk assessment, is if they're a moderate risk, we're also asking them not only to see the client, but also to reach out to the collaterals that are working with that client and to check in with those collaterals as well. And we're asking them to keep the cases open for 6 months, and then we would reevaluate whether or not we received another report on these individuals, or whether or not the case was at a point that we could close the case. So as I said before, we did find that, some clients are not always eager to have our involvement, and they don't want us to open a case. And so we've been trying to work with staff on how to engage those difficult clients. And so sometimes we've gone out and we've seen somebody and they say, no, we don't want we don't want continued involvement. So the worker has come back and the supervisors looked at that, and I'll give you an example. In one of our offices, we had, it was a hot spell here, hard to believe in New Hampshire, but we did have a hot spell, and we had a client that was living in very hazardous conditions, squalor, and it was just he lived in a cabin, and it was very hot in there, and he was dehydrated, and he was malnourished, and he was not looking well. And so the worker came back and said to the supervisor, he's not doing well, but he does not want us to stay involved. He's refusing to go to the hospital. He's refusing to see a doctor. And the supervisor looked at it with the social worker and said, well, then let's go back out. And they went back out, and on the way to the client's home, the supervisor stopped and bought some popsicles and engaged the client with, they offered him a popsicle, and as he ate the popsicle, they talked about things, and at the end he said, yeah, I guess I'll go to the hospital. And so we were able to help move that along. And I have other examples of those kinds of situations where we go back, even though the client said no. And of course, we're very careful about not harassing people at the same time, and I think that's a balance that we have to strike. What has made the relationship with the contractors work? It's been a very, very positive relationship for New Hampshire. We can't speak highly enough of NCCD and how they've interacted with us. They've been available to us. They've been flexible. They really came in and they learned about New Hampshire and about adult protective services in New Hampshire and about our statute and about our rules. And they really listened to what the work group had to say. And they went through the process with us. And they provided a lot of technical assistance to us. And we've just been very pleased to be engaged in this process. And we are still very committed to our structured decision making. And we're anxious to see the final assessment tool when it comes out. And we will continue working with the contractors until that time, and we will continue, looking at our practice. And we just think this has been a wonderful way to be able to evaluate our work.
Both Kristen and Rachel have mentioned the fact that I guess the predecessor of this was used in the child protective context. I was wondering if either Rachel or Kristen could talk a little bit about how successfully it's been used in that context. Has it actually been a viable tool, or has it sort of mixed? I assume it's been viable given the fact that you're trying it in this context, but it'd be helpful to hear sort of how it's actually played out in that context. Can either of you address that?
Do you want me to take a first stab, Rachel?
Sure.
I think a lot of the issues that Rachel mentioned play into that. It has shown to be effective in some jurisdictions. We've done impact evaluations in foster care and in the investigation process. And having structure added to clinical decision making has shown to reduce rates of re-maltreatment in child welfare, but in some sites. And I think the implementation, the support at the agency level, right, there's a number of factors. Places that implement it and it's a piece of paper that they complete, then there's no impact on practice. I think if it's partnered with the intensive look at practice that Rachel described, then it has been effective. But it's just one piece of information, right? I mean, there has to be, I think, agency support at every level. Having supervisors use the risk assessment as an engagement technique with a worker to find out, if I, for example, indicate that a person has substance use, Rachel as a supervisor might want to talk with me. Well, what's the evidence? You checked that risk factor, but what is the evidence that you're basing this on? Those types of discussions, I think, are key to really improving practice. So the implementation piece is critical.
And do you know whether or not in the child context they track when the agency or their office does not use structured decision making, and to see whether or not it affects the outcomes in that scenario?
I don't know how much people are evaluating their own practice internally. We know who has contracted with us for services, and the validation. NCCD does not do all of the validation studies. We'll often have states, for example, Iowa, borrowed Colorado's risk assessment, and this is child welfare. So Iowa Child Welfare borrowed Colorado Child Welfare's risk assessment and then contracted with University of Iowa to validate it. And then we provided assistance to help that professor do the work. I don't know how much people are using SDM to evaluate its impact on practice. I think in a lot of places, or I should say in some places, I worry that people pick up the assessments thinking that this will improve practice. And it's really, right, it's almost a diagnostic tool. It's really, it can help improve practice, but you have to have those other components. It has to be the comprehensive picture.
Thank you. Another question is, maybe, I don't know if, Kristen, you're probably the one to answer the question, is IRBs. As part of this particular project, did you have to obtain IRB approval?
We did. We did. It was expedited because we didn't actually have direct contact with clients. So it was an expedited review, but we did have to obtain IRB approval. And we have had to for the child welfare studies as well. And I think that's the right thing to do. That was a quick answer. You want me to keep talking about it? Are there other questions related to IRB?
Hi, everyone. Sorry about that. I experienced my own technical difficulty. Kristen, I was wondering if you could talk a little bit about the IRB approval process generally for those folks that haven't been engaged in research, haven't done something like this before. What does that process entail?
Sure. The IRB process is, usually universities have, it's called a Human Subject Review Board. And all projects, really, every research project should be vetted by a Human Subjects Review to ensure that client rights and safety are protected. So it's a process where you submit exactly what you're going to do. So you have to know exactly what you're going to do in the research protocols and your instruments. And then for federal grants, there are federal boards through which you obtain IRB approval. Or you can go, NCCD has its own internal. We have board members that serve as a preliminary Human Subjects Review Board. And then I mentioned the universities, they have theirs. But essentially, you submit your research plan, and you are documenting exactly how you are protecting client risk. For us, again, because we didn't have direct contact with clients, it was about how are we going to protect the confidentiality of data. And, and is there any risk? And because the risk assessment, when we put it into place, phase 1 and phase 2, the procedures that Rachel described, I mean, clinical judgment can override the risk level, right? So a worker can make their own decision. What we would just ask, right, is that they discuss it with Rachel, their supervisor, or whoever their supervisor is. And so that is how we protected client interests. If there were a mandated action resulting from the risk level, I would be more nervous, and I would expect the Human Subjects Review Board to come back and question me. So it's basically an intensive review, and there's a lot of trainings online. For instance, University of Wisconsin-Madison has a Human Subjects Review certificate program that I think almost anyone can go through. But there are federal programs, so you can find a Human Subjects Review Board and go through the test and the education piece, and that will provide you a lot of information about why Human Subjects Review is necessary.
Great, thank you. I had another question for Rachel. The question was, how did the risk assessment tool impact the number of cases that had ongoing involvement with APS?
Can you repeat that, Andy?
The question was, how did the risk assessment tool or program, how has it impacted the number of cases that had ongoing involvement with APS, if it has?
I'm not sure we have that we have been able to narrow that down yet. what we've seen in practice is that we are not seeing the number of moderate and high-risk level cases open that we would think that we should be seeing. We're still seeing a lot of the low-risk cases being open, and part of that, I think, is because of the way our system is designed, and we're trying to work on some of our systems issues we have, and by saying that how our system is designed, we have services that we can provide to a client that may be like a one-time service. For instance, this time of year, somebody may need fuel oil, and so that may be a service that we would provide to even, to a low-risk client. But in order to do that, we have to go through and open a case. So our data system doesn't distinguish, that it only distinguishes it's an open case or not, and it doesn't necessarily at this point show us it's open because it's high risk. So we're having to kind of do a manual check on that. But as we improve our system so it's more in line with our SDM policy, I think we'll be able to better answer that question.
It is we will look at it. It's a good thing for us to look at. So thanks for mentioning it.
A question for Kathleen. A number of people, both on the sort of call and otherwise, have talked about the importance of evaluating outcomes in terms of APS interventions. I was wondering if you could talk a little bit about the challenges of sort of developing, national standards or national data collection efforts in this regard.
I'll be happy to. Different from the child welfare system, Child Protective Services, which supports with really substantial federal funding, data systems training, caseload standards, all kinds of things. There really is no designated federal funding for APS. So every APS program has evolved on its own within each state and in some states within counties. So that means that people have different data systems, may be collecting largely the same but not completely the same data elements, may define things differently, may capture things by different age ranges. It makes it very, very hard to, there is no national adult protective services database, which is extremely unfortunate. We are doing a survey right now, going to go out in the next day or two, of state APS programs, and we're going to ask just really a very basic set of data elements to determine if states are collecting those data elements, and maybe we can start to put together at least a minimal data set concerning APS. It's really a big challenge. You can't argue that you need resources if you can't tell people what you're already doing, and it makes it really hard to tell people what we're doing because we can't collect the information nationally. But we're hoping our survey will establish a basic, comprehensive picture of APS, both nationally and in each state in 2012, and that'll be something we can build upon.
Great. Another question that involves sort of what is a desirable outcome in terms of an APS intervention. Do you think there's a consensus in terms of?
No, I laughed because that's a really, really difficult question. One of the key parts of that question is whose outcome. So say you have a self-neglector whose property's run down and, there's tall plants everywhere and whatever, maybe lots of animals, and so getting that person out of the house and the house cleaned up, etc., that's a good outcome for the neighbor who reported that case. But the client may not think it's a good outcome at all. It may be a horrible outcome for that client whose safety and security is somehow tied up with being surrounded by all their things. The APS worker sees a reduction in risk and, stability, no further deterioration in health, etc., as a positive outcome. Sometimes clients may be moved to another setting, to a long-term care setting, or to another family member because they can no longer take care of themselves and maybe not really able to give consent one way or another. But they may not be happy with that move. They really may want to be at home with the person who is neglecting them. So it's really hard, but for APS, you could say we reduce that person's risk. They're no longer being neglected by the alcoholic son who is supposed to be taking care of them. But that mother, maybe it's not somebody with dementia, that mother may be, really consumed with guilt and worry about that son, and even though she's safe from the neglect, she may not think that's a positive outcome. So it's very, very complex to think about what outcomes are, and I think we have to, this is actually something the research committee has just started touching on, is how do we define outcome and how do we measure that outcome. And I don't know if Lori Delagrammaticus is on the call from California, but she has put some thought into this in terms of weighing outcomes in terms of safety and so on. So that's a really important topic.
Something that both Rachel and Kristen mentioned, probably Rachel, actually and Kathleen as well, is that one hurdle to getting APS agencies involved and willing to assist with the research is the resources that are necessary and how they take away from efforts that should be elsewhere. I was wondering if Rachel could talk a little bit about how she was able to persuade her agency and her colleagues to basically devote the time necessary to do the research, and also to clarify whether or not, I assume this was the only sort of research project you were working on at the time, or were there multiple research projects that you were simultaneously assisting with?
As I said, our agency was very committed to this project, and it was from the top down. And I think that really helped because it did, free people up. And I know that, as I said, Sally was our project coordinator, and that was very important. Part of her duties were specifically for our structured decision-making process and developing that and implementing that and facilitating that process for us. And that was very important. And again, we had received a grant so that we could have that, have her designate a good chunk of her time toward the project. I think the field staff, they were very interested in it because they knew it was going to impact them as well as the supervisors, and so I think they were very committed. And it was interesting, I think, as the group evolved. I think many people came in, and they, I think, had the mindset, well, okay, we're here because we know we're going to have to live with this, and so we want to make sure it's something we can live with. And then as we went along, they really saw the value in what we were doing, and I think our attendance rate at all our meetings was very high. People made an effort to be there. They were very interested in this, and they could see how it was going to impact in a positive way. And they were concerned, and they wanted to be part of the discussion, as to what really made somebody unsafe, or what kinds of cases really should be opened. They wanted to be part of that, so they made the commitment to be here. And again, we are a small state. And so that may make a difference for people who are looking at this kind of undertaking. So for New Hampshire, I think a person might have to travel 3 hours to a meeting, whereas in other states it might be much longer than that. It might not be as doable. But we met fairly frequently, I think probably about bi-monthly, and people did. They found the time to be here. And I think it was because, again, I can't speak highly enough of our administration just supporting this effort. And again, I think they supported it because some of the people in our administration had come from the child welfare system and saw the value and the benefit and what it had done for their practice. They saw it as being very successful in child protection.
Actually, this dovetails with the question that just came in. I was wondering for either Rachel or for Kristen, was the research done in both rural areas and urban areas? And if so, was there any noticeable distinction in terms of the data resulting?
It was. We've collected statewide data. In the process evaluation, we had both focus groups and an online survey. So we obtained feedback from every APS worker and supervisor if possible. And then again, the data is statewide. So we'll take a look at that. Certainly I'm not sure if there was a difference. I mean, there are practice differences. Like when we were on site for the process evaluation, people talked in the northern part of the state, talked about how difficult it was to see clients and make the contact standards, and that they just had more travel time. And so I think there are practice implications. For the performance of the risk assessment, we're going to look at it for the validation study. So this webinar has been useful. It gives us a number of things to investigate.
Great. I guess we're sort of slowing down a little bit. I want to give each one of the speakers an opportunity to give any sort of advice to either APS agencies or to researchers who want to do research in the field of elder mistreatment. Any sort of last words of wisdom or pearls of advice to give to folks? Kathleen, try to throw you on the bus first.
Sure. I want to address something that has come up in the chat room, and if some of you haven't been following it, it's why do people call APS and then it seems like nothing's done, or the cases aren't accepted? And I answered the question in the chat room by saying that some states, counties have really strict definitions of what constitutes vulnerable, so people may not be eligible. But what I didn't say, and I feel like I need to say to everyone, is that APS has a very, very strong ethic of an adult has a right to make their own decisions, the right to self-determination. So unless there's a screening that clearly shows, an evaluation that shows that the person does lack cognitive capacity, the client can say, I don't want anything done. I don't want my house cleaned up. I don't want my son thrown out, whatever it is. And that's really, just a guiding ethic. And I'm very happy Andy Capehart put up a link in the chat room to the NAPSA Code of Ethics about APS, because you'll see that that is the principal foundation on which APS work is based. So, it's always a fine line trying to balance the right to self-determination with the need to protect people who are unable to protect themselves. And it's just a really tight wire that APS walks in every case. So I just wanted to put that out there. In terms of words of wisdom, I'm just going to state the obvious, and that is that we really, really need research into elder abuse, abuse of younger adults with disabilities, and adult protective services. Is what we're doing effective? Can it be more effective? Is there a better way to do it? Can we, do the screening that will get us out right away to the really high-risk cases? Are there certain interventions that we could put in effect in certain kinds of cases that, based on the evidence, will make a difference? Are there ways we can get in there and save the money quicker so people are not totally sent into poverty and onto Medicaid? So all those kinds of questions are just out there, and we really need the academic research community to take more of an interest in this field. And I know it's easy to say when you don't have 50, 80 cases on your caseload, but to the extent it's possible, I hope people can, at least APS programs can make their data available, because there is a wealth of data. Let me give you a real quick example. In Utah last year, the legal services developer in Utah now Utah is also a small state in terms of population, went through every substantiated case of financial exploitation in the state over a year period, and she got so much information out of those case files about who was committing the abuse, how much people lost, who was more likely victim, what it was costing Utah every week in terms of elder financial exploitation, how many people went on Medicaid directly as a result, which was about 9% of those victims went on Medicaid directly because they had been financially abused. So that's just an example of the kind of rich sets of data that could be obtained if people have the time and the interest and the funding to undertake more work. Thank you.
Great, thank you. Kristen?
For Yeah, my first thought, probably because Kathleen mentioned it, for universities, I would just encourage them to talk to their partners. You know, University of Wisconsin-Madison folks here have collaborations with child welfare and APS, and I just think that if you talk to practitioners or administrators, they will tell you what they need. So if you're looking for research questions, you can probably find them from your practitioners. I know that, you know, it was a conversation with Rachel that led me to want to look at the consistency of intervention decisions between APS workers and police or a district attorney. You know, what is the level of evidence needed, and could we improve that consistency, and would that help? You know, I just think there's so many questions. Would that help APS workers if they knew what standards they had to meet in order for the police to intervene or follow up? You know, would that improve the effectiveness and their time spent? And then I mandated reporters, you know, and education of reporters. We don't know how effective that is. So I think there's a lot of issues to be studied, and I think talking to people in the field is a great place to start.
Great, thank you. Rachel? Okay, it appears we may have lost Rachel.
Hello, I'm here.
Okay, Rachel.
I think just to echo what Kathleen said, it does, our whole SDM, our whole set of instruments that we use for SDM does give us a lot of data that will help us with where are our gaps in services, where should we be putting our resources. I think one of the things that the risk assessment and also our other SDM tools have been able to provide me is that when I go out and speak in public, and I think this goes to the, my screen is still blank, but I think it goes to the chat room discussion, is when I go out and speak in public, I can talk with people about what our process is, and I can say that this is how we look at intake, and I can reference our structured decision-making tool for intake, and I can talk to people about the safety assessment that we do and about the safety planning that we do depending on how our safety assessment comes out. And I can talk to them about the risk assessment and how the workers are to try to engage those moderate and high-risk clients. And it really has helped demystify our process to the public, and and to new workers. We've had originally, when we started out with structured decision making, we had a very seasoned staff, and since that time we've had many people retire, and we've brought new people on, and it's really been a great training tool and orientation tool for new workers. So I think you know, I would encourage people to seriously look at using the risk assessment or something similar. And just one parting comment is that New Hampshire, we're always willing to consult with people and talk about what our experience has been, and hopefully if that's helpful to people, we're more than happy to share that with folks.
Great, thank you, Rachel. I think with that, we're going to bring this webinar to a close. To the extent that anybody has any other questions, you can feel free to reach out to the Innovations Research site, and they should have a link to convey any questions there, as well as all the materials should still be on there. So to the extent that anybody wants to either look at the slides that were put up or the actual risk assessment tool, those will also be available on the resource site. So again, thank you to all the panelists for participating, as well as the Kennedy School and the National Institute of Justice for hosting this webinar. And one last plug, given the number of people who express an interest on risk assessment tools, I think there will be an effort to have another webinar focusing solely on that type of tool. There is some exciting research being done on, in addition to the one discussed today by others. And so I think that probably warrants another separate discussion. So